is my pleasure to welcome our speaker, Dr. Hannah Snyder. Dr. Snyder is an assistant professor at George Washington University in DC, and she is also the psychologist in the Child and Adolescent Protection Center. She got her undergraduate degree at Northwestern in psychology and Spanish, and actually speaks Spanish pretty well. And she went then to graduate school at George Washington University, where she got her PhD in clinical psychology. And after an internship in Miami at the Institute for Child and Family Health, she returned to GW for a postdoc. And so she's been there now for several years, and today she's talking about evidence-based interventions for child maltreatment.
Oh, okay. Okay, thank you guys all for your patience. So yes, I'm Hannah Snyder. I'm from Washington, DC. I'll talk about.
Can you advance?
Okay. I'm sorry, I went a little too far. Okay, so I'll just start again with a little bit about me, some of the review of child maltreatment, and then some therapeutic approaches that I take, as well as the assessment and research that I do at Children's National Hospital in Washington, DC. So quickly about me. So I born and raised in right outside DC, then moved to Chicago, or right outside Chicago, for undergrad, did bachelor's in Spanish and psychology, then moved back up the East Coast to get my PhD in clinical psychology at George Washington University, came to Miami for Institute for Child Family Health internship, then a postdoc at Children's. My first licensed position was at a private practice right at the start of COVID. So a lot of telehealth, and that was in Washington, DC and in Virginia. And then my faculty position currently at Children's National with a faculty attending position supported through George Washington University's School of Medicine. So at CAPC, which is what we call our Child and Adolescent Protection Center in Children's, I do a variety of things: teaching, research, and clinical practice, as well as supervising trainees and integrating care. For many of you all, this is a review, but there's a variety of types of maltreatment that we see at CAPC. So neglect, right? The failure of parent or other person with responsibility for a child to provide basic needs. So this can be hygiene, this can be medical care, it can be educational neglect as well. Physical maltreatment, so a non-accidental physical injury, or any action that results in physical impairment to the child. The psychological and emotional maltreatment, which is a pattern of behaviors that impact a child's emotional development or sense of self worth. So those can be like constant criticism, withholding love, support, rejection, shaming, and belittling. We also see sexual abuse, which is, under the U.S. statute is employment, use, persuasion, inducement, enticement, or of coercion of any child to engage in or assist in any other person to engage in this sexually explicit conduct or simulation of such conduct for the purpose of producing a visual depiction of such conduct, or rape, molestation, prostitution, or other forms of sexual exploitation, which can also include the commercial sexual exploitation, which we specifically have a one team that sees only seaside commercial sexual exploitation of children. And we also see children who are seen under torture. The torture statute is when it's defined medically as at least 2 physical assaults occurring over at least 2 incidents, or a single extended incident, which could cause prolonged physical pain, emotional distress, bodily injury, or death, and at least 2 elements of psychological abuse, which is isolation, intimidation, emotional or psychological maltreatment, terrorizing, and then neglect is also frequently present. which is often manifested as a failure to seek appropriate care for injuries or malnutrition. We see a fair amount of each of these types of maltreatment. The torture is specifically the medical definition, and it's also something that in DC is prosecuted. It can be a criminal prosecution specific statute. So as just a review, this scope of our traumatic events, more than 60% of youth will experience a potentially traumatic event, right? There's single incident traumas, a terrorist attack, a natural disaster, a single episode of experiencing violence or injury or abuse, as well as chronic, complex or repetitive traumas. Commonly, youth will experience chronic stressors and then a subsequent severe event, such as an assault. And that's frequently what we see at CAPC, especially within therapy, is that we see kids who are experiencing chronic stress and chronic complex trauma. And it's harder to do sort of one single incident at a time because it's frequently just compiling. No one talk would be complete without talking about ACEs. I know for a lot of people, we know where this comes from, but when I was reading The Deepest Well, I didn't realize the full background to the ACEs study, and that, in 1985, Dr. Felitti, the chief of Kaiser Permanente's Department of Preventative Medicine, couldn't figure out why more than half of his people in his obesity clinic were dropping out each year for 5 years straight. And so he was basically, a lot of the people who had dropped out had successfully lost weight. And he decided to sit in on a couple face-to-face interviews with these dropouts. And he used this standard set of questions and weeks and weeks and weeks, nothing. And then by mistake, instead of asking, how old were you when you were first sexually active, he asked, how much did you weigh when you were first sexually active? And the patient answered 40 pounds and burst into tears and added, it was when I was 4 with my father. And I didn't know this backstory to this really seminal ACEs study that we all talk about. And I think one of the things that for my practice is I find that stories are compelling. We learn from stories and we remember stories. And so in this sort of, when he was writing about this, he said, he sort of remembered thinking, this is really the second case of incest that I'd had in 23 years of practice. And he said, I didn't know what to do with this. But then 10 days later, another person disclosed childhood sexual abuse. And so then he connected with Dr. Robert Anda at the CDC, and together they added surveys, and initial surveys began in 1985, and they followed participants for more than 15 years. And they found that early diversity has lasting impact. And so about 2/3 of the adults in the study had at least an ACE score of 2. And the higher number of the ACE score, the folks had higher risk of significant health impairments afterwards. And I found this particular slide incredibly compelling because I think when we talk about the generational embodiment and historical trauma, that's not only about the initial caregiver, but even further back, when we think about the mechanism by which adverse childhood experiences influence throughout the lifespan. And so we know, again, the more ACEs that a child has, the higher risk for developing chronic illnesses such as heart disease, COPD, depression, cancer. And things get really serious around an ACE score of 4 compared to people with an ACE score of 0. Those with 4 categories of ACEs had a 240% greater risk of hepatitis, 390% greater, more likely to have COPD, and 240% more likely to have an sexually transmitted infection or disease. So pretty compelling, interesting stories. And I had never, again, like I said, heard that that backstory to sort of the inception of this study. And I think it really also speaks to, I think, a lot that we can support our medical professionals in learning about how to ask questions and then what to do with that information. Because I've often heard some medical providers say, I'm going to ask this question, and I say, and then what are you going to do? Because there's a lot of providers who say, well, I want to know about their childhood experiences. And I say, okay, great. And then what? Because if you say, oh, have you had any childhood sexual experience, abuse? And that person says, yes, what are you going to say next? And how are you going to say it? What are you going to, how can you sit with that and support them? Because asking a question, checking it off on your list is important to ask. And also what comes next. Because I think a lot of times and a lot of a lot of the trainees that I work with are ready to ask these questions to support patients. And also we need to know, what are you going to do with the patient in the room if they disassociate or whatever? Because it's asking is important, and that's the first step. So one of the things that I speak with families a lot about, though, is that the risk of PTSD, right? Most youth exposed to a trauma display maybe an immediate transient behavioral mood arousal disturbance. And about a third, though, experience enduring traumatic stress. Frequently, I also share this with parents or caregivers when they're bringing in a child that has experienced an assault, either by another family member, a daycare provider, something. The question is, are they, what's going to happen next? Are they going to be okay? Are they going to be, if it's a sexual assault, are they, destined to have problems forever? Are they ever going to be healed? And so I frequently refer to this, that, a third manifest enduring traumatic stress. And then also we know that a supportive, consistent caregiver is one of the greatest buffers in terms of preventing that and supporting the child through that. The other thing is, we know that the risk of developing PTSD is greater for those with complex or repeated trauma as opposed to single incident traumas. There's research that chronically children who are exposed to chronic trauma experiences have almost double the rate of psychiatric disorders. So it's pretty, when we think about chronic stress, whether it's chronic stress from chronic exposure to community violence, repeated exposure to violence within the family, the outcomes are more difficult. So what do we do with that, right? That's a lot of things that make the cases that we see the families very distressed when they're coming into the Child and Adolescent Protection Center. Some of them are not there by choice. Some of them are not happy to be there, and they will share that with you. And so even when I'm not in therapy, what is my approach, right? Even if it's a shorter interaction, I'm often meeting someone after the worst moments of their lives. And so really at the center of it is child and family centered. I take a lot from attachment, development, CBT. And one of the things I do a lot of is I frame things as grief and loss. I was fortunate to train at in DC, there's the Went Center for Grief and Loss, and that's all they do. And I did a 6-month program with them. And even though many of the grief or losses here are not the death of someone, they are also honoring that what we had before is different from what we have now, and sitting with the loss of what you thought your child's life might look like, what you thought relationships would look like if, for example, the person who is the alleged abuser is within your family, and now that whole relationship within the family is different. And there's so many people in the family saying, oh, well, just, Uncle so-and-so didn't mean it. Just, he's fine. He's around. And so, grieving the loss of the family system. And so I know this may not seem as evidence-based in terms of we're not sitting there, I'm not always sitting there following a manualized protocol, but they, this adaptable and flexible, and shared decision-making really helps support the family, and honoring that identity and the innate knowledge that the families come with, right? I don't know what it's like to live in their shoes, but I can point out what we know and sort of guide them in that way. I know I tell families all the time, I'm not headed home with you and your screaming child after you said no to the candy bar in the aisle. I don't, we have 45 minutes in my office and I've coached you through it, but you're the one who's walking down the street or having to watch, everyone look at you and like screaming child and making comments about your child in the grocery aisles. But when you leave my office, so does the screaming child. And so it's a lot easier for me to stay regulated. And I try to share that to empower that I'm not necessarily better at this. It's a different situation. And so I, really from this integrated child and family centered approach, the relational approach, and also interdisciplinary. And I'll talk a lot about the interdisciplinary work that I do at CAPC because we work very closely with medical and legal providers as well. And I think that when we think about this from advancing these evidence-based interventions, what we know from the evidence, and how we can support the traumatic, the experiences of the trauma. So just to sort of one of the, I did talk about this honoring identity, and I want to talk a little bit more about these contextual. And I know one of the things is cultural humility. I say this frequently. I was born on second. I didn't hit a double. I know that my presenting, in different areas of my life, have more proximity to privilege than in others, and that is something to understand and approach the diverse trauma responses and parenting practices, and that through these close and secure interpersonal relationships, for example, infants and toddlers learn what other people expect of them. And that's a lot of that is culturally bound, as well as, cultures that lens through which children and adults learn the rules of relationships. And it can affect and influence communication style, emotional expression, emotional regulation, and parenting goals as well. And so we, one of the things that, is not only kind of a footnote in the work is really looking to address the equity and access for our families. One of the things is, Children's National, we are situated in a very there's a lot of public transportation within Washington, D.C., and yet the actual hospital is not easily accessible from the metro. You have to take a metro to a metro stop, and then there's a shuttle that runs every so often, and then that shuttle goes to the hospital, and hopefully you get back on the shuttle afterwards, or you can pay for parking, which can be upwards of $20 a day, right? Or you can pay for an Uber, right? And then you also have the lost wages, and are you allowed to take off from work? And all of these things really affect how much access you actually can have. And so thinking about, can we, one of the things is we actually applied for grant funding for parking passes, right? Just knowing that, because in addition to your copay for therapy, now you weekly have to pay for parking. And if you have more than one child being seen, or your child has medical care also, that's quite a lot. And then you also have to leave room for the parking because, of course, depending on what time of day you get there, you might be waiting a while for space. And then, tailoring the interventions to align with cultural values, and also language preferences and language comfort. And, one of the things that, again, I speak to with from grief work is really thinking about sitting with the distress, the anger, the sadness, the fear, taking from of the sort of the liberation psychology. There are modifications we can make to EBTs to support chronic stress and racial adjustment, but testimonios are a verbal journey of a witness who seeks to reveal the racial, class, gendered, and nativist injustices they have suffered as a means of healing, empowerment, and advocacy for a human present and future. And so that's taken from liberation psychology, but one of the things in grief work they say is you can never sit with more pain than you can sit with your own pain. So that ability to sit with, right? One of the things they talk about is in grief and people in general say, don't just stand there, do something. But in grief work, it's don't just do something, stand there to sit with and be present and witness. And then we can work. But a lot of things that are happening, distress and sadness is not a pathological reaction. It's not inappropriate. It's not something that we DSM classify as outside of the scope of regular over a reaction that we would expect. It's appropriate. And so how do we sit with at the very least, and then we can think about what else we can do, but really sitting with that distress and anger and fear. And I think that's one of the other things that we had to take as part of the hospital de-escalation training. We had to do, this whole simulation. We were in a simulation lab, which as a psychologist, I had never really been in. But I mean, they had like a baby with it was DSATs and there was all these buttons and tubes and it was beeping and they had a actor playing distressed parents. And it's interesting because afterwards I talked to someone else within a different group and they must have had a different actor or something. She said they were just screaming at the top of their lungs because whatever the simulation that their group is, they did not de-escalate very quickly. But our group, one of the things I said to her is I said, tell me your child's name. She said, you seem really scared. This is really scary. And just honoring and sitting with her and saying, I said, would you like to hold my hand? She said, no. I said, okay, that's fine. Okay. Another group, someone was like putting their hand on their shoulder. She was like, I don't want to do this. And so sitting with that, right? I can sit with a lot of distress. I think a lot of people, it's hard to, right? So sitting with is the first thing I always say, right? And honoring that you are also doing something even when you're sitting there with them. So again, going back to this relational framework, right? The tasks of childhood, I love this quote, is it's enormous, right? And the significance of each task and impact of the completion of these to later outcomes are profound. And so, right, babies learn what they can expect of others, what people can expect of them, how to manage and regulate feelings, and that they're worthy of good care. And right, what we learn that I'm worthy, right? We also see then one of the things that we see at CAPC is because we see a lot of kids who we've seen in clinic for sexual assault or exposure to, witnessing domestic violence, and we see them at 6, 7. And unfortunately, then we see them frequently in our CSEC program when they're 12. And we've seen them being in kind of a trafficking situation. And we see them again as often as parents, as teenagers. So it's one of the things is it starts so young and we can make what I feel is very hopeful is that those interventions and support the families in changing the relational framework that they can expect and can provide for their children and babies. This responsive relationships, right? And one of the other things is, right, I love this, resilience requires relationships, not rugged individualism, which I think is one of the things we frequently miss within our often Eurocentric communities, that there's no limit on how many secure attachments you can have. I talk to families, foster families all the time, that you are by showing this, building a secure attachment, it's not saying that you're superseding or getting rid of their initial attachment to their caregiver. You're, um, you know, adding and buffering and giving more, and that you can have secure attachments also with as so many different caregivers. And so the other thing, this is, young children who've exposed to adversity or violence do not invariably develop these stress-related disorders or grow up to be violent adults, which is a common concern that we are hearing from families who've had children who've been in these experiences. So a couple of the evidence-based interventions that I pull from that are more structured, the trauma-focused CBT. One of the things that I find with cognitive behavioral, trauma-focused cognitive behavioral family with therapy with some of our kids that we see is there's a lot of focus on verbal tasks and understanding. And a lot of the kids that we see, we have to really, really adjust this to be much more experiential, adding in somatic work or adding in things that don't require someone to be able to verbally express themselves, and not just from this is oh, you're avoiding talking about it, but rather this is specifically a harder task, right? And so one of the things that actually I was really exposed to here in Miami on internship was the child parent psychotherapy. And, as we know from the latest research that comes out about the epigenetics and the sort of the change on a sort of cellular level, I find so exciting because that's, as we seen previously, where we see a lot of that stress living in the body, and that knowing that CPP can support that change and support that growth for the family is pretty wonderful from also a preventative measure, right? Not only coming in to sort of treat, but also say, can we put you and help support you on a different path? And then the other interventions, excuse me, our So-Called Security Parent Program, and then PCIT, which I won't spend too much time talking about because I know that here is there's quite more experts than I am in PCIT. But one of the things I was actually sharing is that it's the other thing about PCIT that I find fascinating is how many, kind of just modified PCIT things that you can do. There's even PCIT for problematic sexual behaviors. There's PCIT for so many different kind of types of, there's these modifications. And I think, again, that is pretty cool is that also you see so much change and support for the family in the CDI phase that a lot of the families that I work with, they're like, you know what, I actually don't maybe need to keep going with the PDI. And I hear what you're saying, and sometimes I think from a preventative standpoint in terms of the physical corporal punishment, I'm like, well, let's see if we can talk a little bit through about some of that. But we see so much change in terms of the CDI, and that's pretty exciting. One thing I'll say, and this is not always, at least in my PhD program, was kind of the thing that people didn't really want to talk about, is that the psychotherapy relationship, right, makes a substantial and consistent contribution to patient outcomes, independent to the specific type of psychological treatment, right? And I think a lot of people are like, well, it's only CBT only. We're going to do CBT and that's it. It's like, okay, well, and it is, what the therapy relationship accounts for so much of improvement in this. And one of the things they talk about is this from this study of the digital deliverance of CBT, that even within one modality, CBT, this working alliance measured at the end predicted 15% of outcome variance. Even in digitally mediated treatments as well as face-to-face. And one of the things I go back to is I think it's interesting is that we talk about CBT as most frequently studied treatment in RCTs, but it's not just because they're the most studied doesn't mean they're always the most compelling. And I always say that, and it's always like something that people are like, oh, we do CBT here, and there's a lot of things that are great for CBT. And I think when I go back to sort of my approach, thinking about there's a lot of place for CBT, but if I sat in front of some of the kids that I work with, their families, and I opened up a book and I said, we're going to just talk about this triangle, and I don't want to hear anything else about your life right now. We're going to see it. That's it. I would probably never see them again. And I wouldn't disagree with that because that would feel so invalidating. And so there's always an and, right? There's the skills and the work and all this important skills that you do learn, and a lot of the change that you do get from CBT. And you are a person in front of me, I'm a person in front of you. And sort of honoring that relationship is also really important. So whenever I talk about evidence-based interventions, I want to say, and we got to remember the relationship. And I find this just very important. And I know it's a little small, but it's from a Canadian hospital, which is why the OUR. But this unexpected behavior, right? A lot of times the families are saying, he's having this tantrum, trigger, always tantrums. Like I have a child I'm working with right now who any visits with his biological mother, and this is the third removal, I'll say, and it's been pretty terrible. I will say he's, by the grace of God, in level 1 trauma neurosurgeons alive. And he spits and kicks and hits his mom every visit. And the therapist for his mother has said to me, well, get us to help us change that behavior. What's the antecedent? And I'm like, mom is the antecedent. She's triggering him right now. Well, can we give him we need the misbehavior. I need what do we do next? Well, there's a lot of doing next. And so again, we have to go beneath the surface. It's not only that he's kicking and hitting and spitting. This is a really dysregulated, traumatized 5-year-old. And if I just tell you, well, that's behavior, here's the consequence, we're missing so much underneath. As well as for mom, because she's not super regulated right now either. So we want to help her support her regulation rather than give you a reward or punishment for that spitting. So I'm going to just shift us a little bit to talk about some of the assessment work that I do, because I think a lot of times we need to do some thorough assessment before we can get to the treatment and intervention. And so the assessments that I do are developmental and then psychological, psychoeducational. The Department of Behavioral Health, where the DC Child and Family Services Agency it's housed, does the majority of, maltreatment evals, like, so I'm not really answering, has this occurred, or what kind of protective, what is the level of risk next? I'm not usually talking about what would be the psychological effect of the child if they return to the parents, or if the parents had their parental rights terminated. Those aren't the questions that I'm usually answering, because there is, in DC, we have a separate, for now, department that does that work. So one of the things that I specifically do presenting is a lot of the abusive head trauma cases that were in hospital and then consulted by one of the child abuse pediatricians, and then are followed up. And so we have this abusive head trauma is this constellation of brain injuries that are caused by directed application of force to an infant or young child. Approximately 20 out of 100,000 children sustain abusive head trauma annually. And it's also the leading cause of fatal head injuries of children younger than 2. The other cases that I see are neglect frequently. A lot of the neglect cases that I see are really, there's a lot of global developmental delays associated with that. Sometimes families or foster families are saying, I think she's on the spectrum. And I'm like, because she's not making eye contact. And I'm like, well, she haven't really had a lot of opportunity in the past year or 2 years of her life. And so one of the cool things that I can do though is I get to follow them and see them make the progress after 7 months and then another 7 months. And so I've had the opportunity to see some pretty amazing growth and healing. The other one that I do is a lot of kind of ADHD, ASD, is it PTSD, is it learning disabilities? Because children with developmental disabilities are between 1.6 and 2.2 times more likely to experience neglect. I'm going to keep moving though, because I don't want to spend too much time on this, because I do a lot of this thorough, right? A lot of differentials. One of the things that I get to do though, because I can spend a little bit more time, is these projective assessments. So I do a lot of Roberts, house, tree, person. I know this was recorded, so I didn't bring any cases, but I find projective drawings really, really helpful and fascinating. I often do that at the start of therapy cases. So draw me a picture of your family doing something together. So kinetic family drawing. Some kids can't even access that, and they're like, nope, that's too triggering right now, so we leave it to later. But one of the big overlaps is PTSD from autism. And this is actually a psychologist that I follow on Instagram, and I just think it's brilliant. And so one of the things that when we think about, especially with PTSD or neglect or maltreatment, is does the lack of interest in peers stem from social withdrawal and attachment difficulty, or a difference in social emotional reciprocity, right? Is the child not sharing emotions or expressing affection as a part of overall reduction in positive feelings, or is it connected to a more general pattern? So I think about it almost like a timeline too. Like, can I create a timeline? Sometimes I can, especially if the family, there's sort of more unreliable narratives, or maybe the family's not great at remembering, or the child is no longer with a biological caregiver. But so thinking about, again, and there's also this higher level of overlap. There's a huge amount of overlap. One of the other things that I talk to families and children and students about is actually this repetitive play. Because in the ADOS, families will say, oh, this is repetitive play. That's all he does. That's all he does. I'm like, well, is it related to a pattern of experiencing or avoiding intrusive memories? Is it traumatic play? Is it they're working something out through their play? I have a kid who he played out coding on my therapy floor, and I have a doctor's kid, and we have a card, and he wanted me to do the paddles, and did it again, and then I had to back him. I didn't have a back, but we made it up. So, a lot of pretty intense traumatic thematic play. And so again, really thinking about, for some kiddos, it's both. Some kids, it's one side, some kids, it's others, but a lot of times helping them get that really thorough evaluation is the first step to making sure they're connected to the right services. So at CAPC, we do a lot of interdisciplinary collaboration. We are part of a multidisciplinary team. Children's is unique in that we sit on, the state lines of DC, Maryland, and Virginia. And so there's a lot of jurisdictional questions about what's reportable in Virginia, or what's reportable in DC or Maryland, or did it happen in DC and then the child now lives in Maryland? So who's captain of the case in terms of the jurisdiction? So again, there's challenges, right? Role clarity, managing secondary trauma, communication barriers. Like, we're all talking about the same thing, but of course we're using different phrases or words or acronyms or 3-letter alphabet soup. But then there's these really wonderful opportunities for holistic care, right? Skill development, learning so much from the physicians and child abuse pediatricians that I work with, being able to, even without our MDT, within from that medical legal side, but being in a hospital, I can I can email a dentist and say, "Is this, what do you think?" Right? This is the child who told me he's using this kind of toothbrush, but he's 7 and that feels really not great. Would you ever recommend this to a child? And they can say no, you know. Um, so, but this also the greater advocacy impact, right? When we're all working together, teaming together for the goal for the child. It's pretty powerful. Um, and then just one thing that I specifically is our in DC, the mental health services, at least for a while, were limited to victims. Our CAC for a while was not allowing anyone with problematic sexual behaviors to come through the front door. They were supposed to use the side door and maybe sometimes and not always. And so, again, there were a lot of limitations for children, even if they did have their own personal history of personal victimization. And so we really saw this gap in our services. And the Office of Attorney General was trying to put more youth and children on the track of diversion rather than, basic pending successful treatment, but rather than sending them to, juvenile justice centers, or youth services, which unfortunately there were a lot of places where that was the only kind of place that you could get specifically therapy targeted for problematic sexual behavior was if you were sent to jail, basically. So we were awarded one through the DC Offices of Victims Services, and then one through U.S. Department of Justice, Office of Juvenile Justice Delinquency Prevention. This last second one that's currently ongoing has been supported by, we get technical assistance from Oklahoma Health Sciences University, which houses the National Center for Sexual Behavior in Youth. And so they have been training our providers on problematic sexual behavior, which was not something that I really ever came across in any of my trauma-focused training. And so what is sexual behavior of youth? Youth-initiated behaviors that involve sexual body parts, potentially harmful, developmentally inappropriate and or illegal, and could reflect a variety of diagnoses. And so there's really a continuum, right? There's typical, cautionary, problematic, and harmful. And one of the ways that so I can leave time for questions, I'm just moving right along, is when are they problematic, right? And I think this is really the most kind of helpful thing is that we think about it as frequency, developmental considerations, and then harm, right? One of the other things is when it's significantly different ages of youth and developmental abilities, and when it is through force, intimidation, or coercion. So our grant goals: reduce these problematic behavior using PSB CBT, create a case review process specifically for problematic sexual behaviors, because a lot of times there'd be sort of kids falling through the cracks, or they'd be assigned to this diversion track but never complete. And so we're really trying to provide more humane and developmentally appropriate goals. PSB for CBT for adolescents is, again, delivered group or family. Caregiver participation is required, which is one of our big outreach things is we can say to the courts, you can't just assign this track without telling the caregivers that they are going to have to be there, because they get there and then they're like, what, I have to come? They're like, yeah, you can't just drop off your team. That's part of the group. And but the big thing that I want to say is that it's this sexual rearrests or reports, 3%, right? That's so huge. We don't always see such an amazing recidivism and wonderful, successful kind of outcomes. Again, the strongest predictor, parent or caregiver involvement. And then the strongest predictor of further problematic is level of caregiver involvement and then past arrests. So again, this is pretty amazing. At this 9-year follow-up, the teens only have a 2% recidivism rate for engaging in any other illegal sexual behavior, and in total only an 8% recidivism for all other types of illegal sexual behavior as adults. And this is really important because I think a lot of places people see them as mini sex offenders. They're not. They're a lot of times youth who have terrible impulse control, way too much exposure to porn, which accounts for about 60% of, I think, 30 to 60% of internet traffic, and very little sex ed, and not a lot of parent oversight. So currently we're doing the family modality, which means weekly sessions, and it varies based on the modules, but most sessions involve individual team time, individual caregiver time, and then combined. The group model is actually pretty great because it's open group and so allows for rolling admissions, but we needed 4 providers to get trained at a time to do group, and we did not have that to do. So we are small but mighty team with the family modality. So that is sort of these evidence-based and lots of different treatments, different types of interventions, because, even assessment can be therapeutic, right? So questions, comments, and then a beautiful springtime picture because it's not like that right now.
Thank you. You could let people in the Zoom world know they could either talk up or send questions via the chat. And while they're doing that, Hannah, I was really interested in the last few slides that you showed. Was that data from OU? Was that Oklahoma University? Was that and was that the results of a randomized trial where there was only 3% citizen?
20. It's not randomized. They were assigned to.
So everybody received that intervention, the CBT intervention in that case, yeah. And the other thing you mentioned that among the issues, these were teens, of course, among the, I guess, predictors of engaging in that behavior was exposure to internet porn. Are there studies, more specific studies on that? I mean, because that's obviously it's increasing incidence, that kind of exposure in the last how many years? What do we know about that?
Well, we know that there's just such unfettered access. There's an interesting quote actually from a actor in porn who talks about how she wouldn't want someone learning about like how to drive from I can't remember, but she basically was like, why are we doing sex ed through porn? And
race car driver or something.
Yeah, from a race car, like why would you get a race car driver teaching your child how to drive? And so there's a lot of like, it's multifactorial sort of how, but for teens, so much is exposure to porn. A lot of them are saying, oh, well, I'm trying this out, or, sharing information, pictures. I learned a lot of different emojis that teens ask for. Ramen noodles means send nudes as an emoji. That's actually how fun things. It's if you text your teens texting, send me, and it's a bowl of the emoji's a bowl of ramen noodles. It means send nudes. So these are the things you learn at PSB trainings. But I would say that porn and the kind of limited regulation or limited supervision of, I've worked with kids who are 6 who have their own personal cell phones and they're on porn and their parents are like, well, he figures out a way. And I'm like, well, he's 6. So you need to be we need to be the caregiver and figure out how to not have that happen. So a lot of it is supervision. A lot of it is, my family talks about it being like native users of technology, that no matter how much like I can try to catch up, even though I was sort of on the native user, I'm not going to know as much. And so families, we always have to talk about, sometimes you just got to take it away. But, internet safety plans are part of it. That's one of the things we actually do is we talk about internet safety plans. But I would say there's, exposure to porn, exposure, lack of sex ed, lack of understanding what does consent mean? and supervision, and then there's some, pathways which are, victimization of themselves. And then there's also other kind of, I would say, impulse and executive functioning, like this is something, an idea I have, and maybe not the best idea to act out. And so having support to space those things out. So there's a lot of different pathways. And I can't think of the paper right now, but there was a paper. One of the things that we do is journal club as part of this grant. And there was a really interesting paper about this sort of pathways to these sexual behaviors, problematic sexual behaviors.
And how, for that, in that study, how did they define problematic sexual behaviors in teens? Because I mean, that's it right there.
Yeah.
Okay.
And that the sort of, this is what makes it problematic is, and then also, right, like it's really just, is it illegal?
I mean, but if they're 16 years old.
Yeah.
It's not, well, I didn't, could you go back to that? Yeah, there. Politically concerning, potentially harmful.
If there's coercion.
Coercion is also
Might be.
one of the biggest ones is coercion. Like, and so there's a different of like if I have to coerce you into engaging this with me, that's no longer, that's problematic, right? If I'm doing something to someone else that they don't feel good about, that's problematic. If it's, 2 6-year-olds who are doing stuff together and they both want to do it together and they're both developmentally 6, not great. We want to look at it, but if it's also not responding to a parental intervention, again, that's problematic. The NCSBY has this really great flip book that you can order that has these little like definitions and as well as like what's age appropriate, what's not. And we've been giving them out to families too, because a lot of times they're, or they're like, I don't want to talk about this with my kid because it's sex. And it's like, well, yes, and we still have to talk about it. So I don't see any, chat. Okay.
Something in the chat.
Something in the chat. Oh, we provide PSB-CBT for school. At Christie House, they do PSB-CBT for school ages 7 to 12. The group format and caregiver participation make it a highly successful treatment approach. Awesome. That's what the next one. Jump to the latest. Is that right? Okay. That's the provider doing the family modality right now, he prefers working with teens. And so he wanted to start with teens. So I was like, enjoy. That's not my preferred population. I have a couple preteens, teens that on my caseload, and that's more than enough for me. That's not my favorite skill. But so we're gonna do hopefully cross train a lot of people at PSB CBT for school age, which is pretty cool. When we got trained, we actually got to go to Oklahoma, and they have a family and youth advisory board, and they came and talked to us and talked about like what it was like going through the model and going through the groups. And that was really cool to talk to the families, because I can't imagine what it would be like if someone showed up on your door and said your son, your daughter did this to another kid. That feels pretty rough. And so they talked about having this group where they weren't alone and how helpful that was.
Or when it's within the family, and
Yes.
tell them you have to keep them separate.
Right.
It's like, really? Or,
Yeah, exactly. And separate doesn't always mean sending them to a different house. It can be supervising, right? Which a lot of people, their old school thought was like, okay, got to get them out of the house. But then there would be no plans for bringing them back into the house. And so, and that's also what we know from, NCBS, ATSA, and other things, is that you don't actually have to physically put them into 2 separate houses.
Large scale sort of epidemiologic type studies that have traced the incidence of problematic sexual behaviors to, exposure to the internet, to internet porn in particular?
I don't know. I mean, I think that'd be an interesting,
I mean, it seems like, others have done the same with depression and anxiety, just with overall, internet use or
eating
social media
disorders.
use in particular, eating disorders and so on.
Yeah.
But I imagine, I mean, I haven't looked into it, but that seems like obvious. Hypothesis.
So I know from the Oklahoma people, like
Yeah.
Jimmy Whitaker is one of my best friends.
Oh, okay.
That they, in the early, when they were first starting this, Barbara Bonner, that they actually, the association seemed to be music. It didn't seem to be exposure. That, you remember, there's more now than there was before.
Yeah.
Right, so that it was perceived to be, like music videos and stuff.
Mm,
And it wasn't frank exposure to sexually explicit material.
Which it is now, for sure.
Well, yeah, because it's so much more access.
Because it's available now.
Yeah, it's way more available, I would assume.
yeah.
And the same thing with self-injurious behavior is completely available online, so it's like, oh, well, I saw it.
And a question,
Mhm.
the approach that you take for assessment and then treatment, are there specific modifications that you make when the child is also a child with a developmental disability? I mean, we kind of have some data that that's a high risk, but the way that they respond to, particularly the way that cognitive behavior therapy and other things have to be modified with those children based on their cognitive level.
Mm.
Have you had experience in terms of what kinds of adaptations are really effective in improving outcomes?
So the TFCBT has a modification of a full manual for children with intellectual disabilities, which I find really helpful. And frankly, I use it with kids even who don't have intellectual disabilities, because I think there's a lot of kids who have who are assigned to TFCBT that it's not oh, okay. I'll read that in a section about taking action. But for child parent psychotherapy, actually there's a lot of work with children with developmental disabilities. And I find that a lot of the times it's also education about how it might show up differently. So one of the kiddos that I worked with, his mom was getting so upset about how often he was talking about it. He was on the spectrum, and he would say his alleged abuser's name frequently, and say something like, "Oh, I saw him last week." And she was like, "What?" And I was like, "Well, I don't think he's actually seen him last week, but he's thinking about it." And so he's talking. And so we talked about like, what can we expect from him? And so a lot of the medications is also from the caregiver, giving them, expectations about what can we expect from a course of treatment. The other thing I'd say is that I find that, again, even somatically, when we go back to the lived bodily experiences, how can I incorporate? You don't need to sit down next to me or across from me at a table while we talk. We move around. When I'm doing developmental assessments, I will sit on the floor. If you want to go through and match pictures on the floor, that's why I'm wearing scrubs. We'll sit on the floor, and then I think also supporting the parents to, again, how can we, because for a lot of families, it's a sort of second injury often to themselves, or a second thing that I have to grieve. That first I have to grieve that maybe my child has a diagnosis that I wasn't prepared for, or expecting or hoping for. And then there's a second diversion from a path, and I'm grieving that. So helping, again, the caregiver grieve and build space around that this is maybe going to look a little different. But
Is there a literature on the effectiveness of those modifications? I'm not familiar with it. But.
So the TFCBT, they are, I think there's some things coming out, at least from my understanding recently about that. For CPP, there are publications about the modifications. And that it is still effective with kids who have developmental disabilities, that we're not losing effectiveness with that. So yes, and I couldn't quote that off the top of my head.
I'm just, the reason I asked that question is that there's a PCORI grant application out right now for comparative effectiveness
Oh.
in developmental disabilities.
Okay.
And it seems like if there is evidence, that would actually be a great opportunity to look at that from the PCORI network. You know, we always kind of struggle with that issue. They want comparisons of interventions with demonstrated effectiveness to be able to do the PCORI grant. And if there's evidence there, it'd be really interesting.
I think TFCBT does have for that one specifically. I don't know of the, other than sort of case studies from CPP, so, but the chat, Josephina Costa was saying, taking action support for families of children with sexual behavior problems from Safer Society Press is very helpful for the caregivers. Great, so very helpful. They have a lot of the NCSBY and also Safer Society Press have really good resources.
Any further questions from the Zoom world?
That was the
That was
last.
the last one,
Yes.
okay. And any more here? If not, I think, thank you so much.